Okay, well, I'm going to go ahead and get us started so that we have plenty of time for our speaker. I'm Bianca Frogner. I'm a professor at University of Washington in the Department of Family Medicine, and I direct the Center for Health Workforce Studies. But more importantly, I'm also part of the leadership team of the Award Network. I'm also the webinar chair, so I'm excited to see you all here today, this morning or afternoon, depending on where you are in the world. We're really excited to have Dr. Kim Powell speak with us today about innovating for rural dementia care. Before we introduce her and get us going, I just always want to provide some housekeeping. As always, our webinars are recorded and you can find them on our website. And we are always welcoming your ideas for future webinar speakers. We have a new slate of webinar committee members, and so we are trying to plan out this next year. So we want to hear from you. And in order to do that, you can scan that QR code there, and there is a link that you can then fill out a form to give us your ideas. Next month, we have a couple of our Award Network fellows giving some updates on their projects. So please join us in hearing what the projects are that the Award Network has been funding and where they are with their projects. And you're going to hear about some of their experiences as they go through their research. So hopefully it'll be a nice interactive session. And then we have a slate of upcoming webinars. And again, you can find those on our website, and I encourage you to register early. If you haven't already noticed, there are these pilot grants that are now open for the National Dementia Workforce Studies. I know many of you are probably experiencing tough times right now, and I do want to acknowledge that. I recognize that the funding environment and just the world around us is particularly tough right now. It's great to see that there's still ongoing funding for some projects, and so I do want to encourage people to check this one out. The deadline for these pilot grant applications is April 28th. There's also going to be an email blast. I don't have a slide on this one, but it should be coming out to you on Thursday that there is a T32 at RAND that had just been opened, and so there's another cycle there that RAND is doing for their T32s, but the application cycle has just opened. So I want to encourage folks to certainly keep an eye out on their email for more details there. So always good to share information about where there might be funding opportunities. And if you hear of any funding opportunities that you think might be of interest to our network members, please feel free to email me or anyone on the Award Network leadership team with any details so we can share it with our community. As always, I want to thank our wonderful webinar committee members who make this series happen. As I mentioned, we have a new slate of webinar committee members. I'm very excited as we rotate on some new folks, but we've also had some folks who have been with us ongoing. Today, we're going to have Jin Jun be our MC for today, and so I thank her ahead of time here for organizing this one today. I also want to thank our leadership members. Joanne Spetz is the PI of the Award Network, but we also have a wonderful group of other leaders who help make all the activities of the Award Network happen. And then, as always, we want to acknowledge our funder, the National Institute on Aging, for their wonderful support for the webinar series and everything that happens with the Award Network. Of course, the views that are expressed in this material do not reflect the official policies of the Department of Health and Human Services, or NIA. So with that, I'm going to stop sharing my slides, and I'm going to ask Jin Jun to please join us and introduce our speaker. Thank you so much.
Well, thank you so much for that introduction, Bianca. Hi, everyone. Good afternoon or good morning. My name is Jin Jun. I am an assistant professor at The Ohio State University. And today I have the pleasure to introduce Dr. Kimberly Powell, who is the speaker. So a little bit more about Dr. Powell. She's an assistant professor at the University of Missouri Sinclair School of Nursing, and she is a nationally recognized leader in health informatics and gerontology. Her research focuses on leveraging digital health solutions, so using patient portals, telehealth, and secure messagings to enhance communication among healthcare providers patients and their caregivers, ultimately providing care coordination and reducing avoidable hospitalization, particularly for those nursing home residents living with Alzheimer's disease and related dementias. Dr. Powell has led multiple federally funded studies supported by the NIH and AHRQ, investigating how health informatic technology can optimize interdisciplinary decision-making and improve patient outcomes. To recognize her contribution and amazing work, she recently was inducted, I believe it was last year in 2024, was inducted as a fellow of the American Medical Informatics Association, and also selected as a Betty Iron Moore Fellow for Nurse Leaders and Innovators, where she's pioneering telehealth solutions to bridge gaps in rural dementia care. And her scholarship has been widely published. She's been honored with numerous awards, including Best Paper in Health Informatics, Health Information Management. And through her interdisciplinary research, Dr. Powell continues to advance the integration of technology-driven solutions to improve quality, safety, and equity in long-term care settings. So with that, I'm going to turn the presentation to you, Dr. Powell.
Thank you so much, Jen. That was such a kind introduction. I appreciate that. I'm just gonna, if you'll bear with me for a moment, I'll get set up here. All right. Well, again, thank you so much. It's such a pleasure to be with you today. Before I kind of jump into the talk, I wanted to take a few minutes and just to acknowledge some of the recent events that have been impacting and threatening our work as researchers. And I wanted to share with you a little bit more about why I feel now more than ever we must stay committed to science and to advocacy. As we sit here today, it's April 2nd, and just one day ago, yesterday, more than 10,000 people were fired from federal agencies, including the CDC, the NIH, and the FDA. And the looming uncertainty that I have felt for months at times now seems unbearable. And I, like many of you, have personal friends whose lives have been upended and whose life work has been questioned, undermined, threatened to be censored, and abruptly halted. For me, it seems nearly impossible to engage in my daily work, but I know I must. I will continue to advocate for better quality of care in nursing homes and for older adults in general. I will continue to be a voice. I will continue to advocate for people like my mother-in-law, who my children call Grandma Mary. Grandma Mary was diagnosed with early onset dementia at the age of 57 and passed away just last year. And even though it feels hard on days like yesterday, especially, and despite the uncertainty that we are facing, I, like all of you, remain here committed to doing this work and to improving care of older adults. When I see headlines like these, it reminds me of where we've been and where we have yet to go and improvements that we need to make. And it motivates and compels me to continue doing this work. So I share with you these thoughts, as we get started, and just wanted to take a moment and acknowledge the things that have been happening before I kind of dive into my presentation today. So it has been an unprecedented time with lots of uncertainty, but yet we continue to do our work and to advocate for what we know is important. So today I'm going to share with you, starting with some background and introduction. Many of you are going to be familiar with this, but just to kind of put us all on a level playing field, and then talk a little bit about the state of the science as it relates to telehealth use in nursing homes, including some preliminary work that's been done by my team as well as others. And then I'll end with an overview of my current study, which is entitled Enhancing Dementia Care, Bridging the Rural Gap with Telehealth, and we'll leave plenty of time for questions and discussion. So I look forward to engaging with all of you in a lively discussion. So just to kind of get us started, I'll share some data that, again, many of you are probably likely familiar with. The worldwide cost of dementia is around 1.3 trillion US dollars, and dementia affects about 55 million people worldwide. About every 3 seconds, a new case of dementia is diagnosed somewhere in the world. And this means that by the year 2031, we will need about 1 million additional direct care workers to meet the needs of this growing population. Nursing homes are an important care setting for residents with dementia. Nursing home There are about 1.3 million nursing home residents in the United States, and about two-thirds of those have a cognitive impairment, such as Alzheimer's disease or a related dementia. And this puts them at high risk for hospital transfer. Nursing home residents with ADRD have increased risk for problems like falls, delirium, functional decline, malnutrition, dehydration, and all of those increase their risk of needing to be transferred to the hospital. Transferring nursing home residents to the hospital is expensive, it's physically and emotionally stressful, and it's often inconsistent with preferences of their residents and their loved ones. In terms of costs, transferring nursing home residents to the hospital results in annual expenditures of about $2.6 billion. And in as many or between 29 and 60% of cases, the transfer is avoidable, meaning that that condition could have been safely managed in the nursing home. So because of this, reducing avoidable nursing home to hospital transfers has become a national priority. And that's because these transfers can have negative effects on residents, including disrupting plans of care, negatively impacting quality of life, and causing physical and emotional stress for patients and their families. Reducing avoidable transfers is quite complicated, and it involves complex decision making and also salient and timely communication among a multidisciplinary care team. Nursing homes that are located in rural areas historically have fewer resources and poorer quality compared to their urban counterparts. Over the past 3 decades, outcomes for rural nursing home residents have worsened with higher death rates and shorter life expectancies. There are dozens of counties in the United States that have no nursing home, and the vast majority of those are located in rural communities where 1 in 5 older adults live. Given the current and projected staffing crisis in nursing homes for both nursing staff and physicians, investigating innovative solutions to ease burden and improve outcomes is imperative. Telehealth could benefit residents, families, and staff by improving access to care and improving outcomes, including avoidable hospital transfers. But before we get into the potential benefit and barriers, let's take a moment and define telehealth and differentiate it from telemedicine. So telehealth is a broad collection of clinical and non-clinical services that use digital information and communication technology to support healthcare delivery. Some examples of non-clinical services that are incorporated into my definition of telehealth are things like staff training, administrative supports, the ability to have administrative meetings, and electronic information sharing. And that is different than telemedicine, which is limited solely to remote clinical services. Before we talk about current telehealth use in nursing homes, I think it's important to consider federal policies that are driving telehealth use. And I think about these in terms of 3 distinct time periods. That is, before the COVID-19 pandemic, during the COVID-19 pandemic, and then after the pandemic up to present day. So pre-pandemic, Medicare coverage for telehealth was largely restricted to certain types of providers, facilities, and services. At the time, beneficiaries were typically required to travel from their homes to approved clinical sites where they could receive care from providers at other locations. In addition, reimbursement for telehealth services during this time was typically lower compared to in-person visits. Then, came the pandemic. So as we all know, this changed life seemingly overnight, and it was especially devastating for nursing homes and nursing home residents. And so during that time, HHS waived many of the restrictions that had previously been in place through waiver authority, and this expanded coverage for beneficiaries during the public health emergency. So during that time, CMS eliminated the originating site requirement, meaning there were no longer geographic restrictions on the originating site of a telehealth visit. And this was particularly important for nursing homes because before the waiver, nursing homes were not an eligible originating site. In addition, the waiver allowed telehealth to be provided by all eligible Medicare providers. It also allowed federally qualified health centers and rural health clinics to serve as distant site providers. And it also allowed coverage of audio-only telehealth visits. And again, this is very important if we consider areas where high-speed internet may not be reliable, such as in rural settings. Then we kind of fast forward to more recent years. After COVID, we see the end of the public health emergency and introduction of numerous pieces of legislation to extend telehealth flexibilities. And while some telehealth provisions have been made permanent, a number of temporary provisions are currently expected to expire on September 30th of this year. These include the waiver of the geographic and originating site restrictions, expansion of eligible practitioners, the option to have audio-only telehealth, the ability of federally qualified health centers and rural health clinics to act as distant site providers, and the in-person requirement for mental health services. So now let's talk about the impact of those policy changes, focusing on two time points specifically. First, in 2020, right after the changes were made, and then second, what's happened kind of more recently. So as you can see, this is a figure from a paper that was published in JAMA Network Open in 2023 showing telemedicine visits in skilled nursing facilities and showing that for both SNF visits and for outpatient visits. And you can see it's very apparent that after those waivers went into effect that I was just talking about in 2020, we see a dramatic spike or uptick in telehealth use. Shortly after the public health emergency was declared, about 15% of all SNF visits, and that's skilled nursing facilities, were delivered via telemedicine. And in fact, 91% of all SNFs used telemedicine at least once in 2020. However, as you can see, this was not sustained. So now I want to share a few studies that my research team did between 2020 and 2022 that kind of sets us up for the current study that we've just started. So this first study was published in the Journal of Applied Clinical Informatics in 2021, and the goal was to elicit perspectives of the consequences of rapid telehealth expansion in nursing homes. And I think, this is something that's very apparent today as we're living through these changes that it seems like every day something new is changing. And it just makes us kind of need to pause and think about unintended consequences that come as a result of rapid policy changes. And so I think we're going to be dealing with some of those unintended consequences for many, many years. And this was absolutely the case also with some of the policies related to telehealth use that were rapidly implemented during the COVID pandemic. So for this study, we used a qualitative descriptive design. We did semi-structured interviews with nursing home administrators and clinicians. And what we found were themes that we organized into kind of 4 different areas. First, what we have are desirable or anticipated consequences of rapid telehealth implementation. And these are things like the benefits of avoiding travel. So it was expected, and probably one of the reasons why the waivers were put into place, so that telehealth could be more accessible for nursing home residents, so that they didn't have to leave the facility, they didn't have to risk being exposed to the COVID-19 virus. So those kinds of benefits fell into this category of desired or anticipated consequences. And then also saving resources. Nursing home administrators talked a lot about how now they didn't have to arrange transportation for residents, and that was saving them both time and money. And then we have desired but unanticipated consequences. And this included things like improved access to care. So I had nursing home administrators where their facility was located in a rural or isolated area who, before the telehealth waivers, did not have access to specialty providers, specifically those who provide behavioral health services. But now, because of the relaxed rules during the pandemic, they did. They also talked about enhanced communication, because now, instead of sending a resident out of the nursing home to the hospital to have a visit, the visit being a telemedicine visit, the nurse from the nursing home was there and able to observe the visit, and so could hear firsthand what the recommendations were versus having to kind of decipher that from documentation or from report or something like that. So those kinds of unanticipated but desirable outcomes we were found in this study. And then we get to some of the undesirable consequences. So providers talked about having a preference for in-person visits rather than virtual encounters, and the difficulty that comes with building a relationship and developing trust that you know, can be more difficult when you're not face to face. So that was one of those undesirable anticipated consequence. And then finally, we get to the classic unintended consequences. So these are the undesirable, unanticipated. And these were things like worsening social isolation for residents, difficulty for residents with cognitive impairment. I recall a nurse that I interviewed during this time who said to me that, you know, her residents with dementia didn't understand why a computer, a screen was talking to them. And that just really created difficulty for that telemedicine encounter. There were lots of descriptions of workflow and technology usability challenges, as you know, some nursing homes were trying to have telemedicine visits using a smartphone or an iPad, and others had really sophisticated integrated equipment. And then workflow challenges where, you know, it was difficult to document, or there was not the interoperability that we need for things to happen seamlessly. And that was just creating some real bottlenecks at this time. And then lastly, and maybe most importantly, was the burden on nursing home staff. And so I will never forget a nursing home administrator explaining to me that during this time, they didn't add staff because there really were no staff to add, but they added to what staff had to do. And I found that just extremely problematic. And so those were kind of the primary findings from this study. And to summarize it, you know, there was promise, you know, there were some positive aspects for using telehealth in nursing homes, such as improved access to care, opportunities for early intervention, and enhanced communication. But in order to achieve or to leverage that promise, we have to mitigate the potential pitfalls. So some of the strategies that we identified in order to do that were things like improved data standardization and interoperability, workforce development, situation-specific best practices. So and this is kind of leading to where my current study is. So, you know, using telemedicine for a patient with dementia might look very different, and the use case might be different from a nursing home resident with a different diagnosis, and then the workflow adjustments that come of that. The next study we published in the Journal of the American Geriatric Society in 2022. And in this study, we used mixed methods to investigate implementation of telehealth in nursing homes during the pandemic, but using a human factors model. So this was a very different approach. And you might be asking, why human factors? Well, human factors is all about fitting the work system to the human. And in so many cases in nursing and in medicine, we have a work system, and then we expect the humans to kind of fit to the system and try to adapt the work that they do to whatever system is in place. And I think anyone that's worked with an electronic medical record has firsthand experience of just this. Well, human factors says we should be doing this in the opposite way. We should be designing the system based on how humans use it. And so to think about this, about telehealth implementation from a human factors perspective, I used a model called the SEEPS model, which stands for Systems Engineering Initiative for Patient Safety. And so to do this study, we used mixed methods. We had national survey data that included telehealth use. And so we took 2 consecutive years of that survey data and put it together with interview data to help develop a really nuanced understanding of this human factors perspective on implementation. And what we found was that 64% of nursing homes increased their telehealth scores from year 1 to year 2. And that's very much what we expected, because remember, this is when all of the waivers were in place. So, they could do telehealth using Zoom. They could use, many different devices. They could bring in providers that had previously been eligible, and they could have the originating site be the nursing home. So we definitely expected nursing homes to increase their telehealth score. We actually expected more than 64%, which leads me to the second bullet, which is that 32% of nursing homes decreased from year 1 to year 2. This was incredibly surprising to us and, again, problematic, because all of the steps that have been taken and put into place were to make this more accessible to nursing homes. Yet between 2020 and 2021, 32% of nursing homes in our national study actually decreased their telehealth scores. So we had, it was a good thing that we had designed a mixed method study, because that allowed us to kind of tease out some of the reasons why that could be. So what we found were the facilitators of implementation were things like training. If the nursing home had taken time to train their staff about how to use telehealth, that was really considered a facilitator of implementation, versus some other nursing homes that they were just kind of doing it on the fly. There was no training. There was just like, here, take this iPad and go, have this telemedicine visit with a resident. The use of integrated equipment, which I think I mentioned a little bit previously, having staff present for the visit was a facilitator, and then using telehealth for different types of visits. So in addition to specialist visits and routine care, the one type of visit that really was different was change in condition. So when a resident had an acute or a noticeable change in condition, to have the ability to get a provider on a telemedicine call with them before making a decision that it potentially could result in a hospital transfer was really an important facilitator of use. And then some of the barriers to implementation in this study were using smartphones, billing, interoperability, and then staffing, which is starting to become a theme. So around this same time, the Committee on the Quality of Care of Nursing Homes began working on a report to describe the care being provided by nursing homes before the pandemic, but was then made manifest by the crisis. And so this group was convened by the National Academies of Science, Engineering, and Medicine, and they were tasked with examining how the U.S. delivers, finances, and regulates quality of nursing home care. So I refer to this as the NASEM report. There are many NASEM reports, but this is the one that is most relevant to this talk and to my work. And the title of this report is The National Imperative to Improve Nursing Home Quality, Honoring Our Commitment to Residents, Families, and Staff. So this report identifies critical opportunities to improve the quality of care through both short and long-term actions that are set forth through 7 broad goals. So, for example, goal 2 in the report is to ensure a well-prepared, empowered, and appropriately compensated workforce. So I'm sure many of the attendees and members of the award network are quite familiar with this. Goal 7 is to adopt health information technology in all nursing homes. And it was quite an honor for us to have our work cited under the Goal 7 goal. And it's the table that you see inset here, which are some of the potential benefits and challenges associated with telehealth use in nursing homes. So now, if we revisit this earlier slide and look at what's happened more recently, we can see that after the initial spike, we see pretty sharp decline, and that initial spike was quite short-lived, really. By 2022, telemedicine visits in skilled nursing facilities had dropped to less than 2% of all visits. So not only do we have low use now into the present, but what we also have is a really wide variation in both the nursing homes that are using telehealth and also the clinicians that are using it. So characteristics of high telemedicine SNFs were those that were located in the Midwest or the West. They were smaller, meaning they had fewer available beds, and they served fewer Black residents. High telehealth clinicians practiced in more rural areas and served more nursing homes. That we can see this demonstrated even further when we kind of take a step back. So this is data from the Kaiser Family Foundation. This is not just nursing homes. So this is telehealth use more broadly. But when we look at how that use varies according to things like geography, race and ethnicity, Medicare eligibility, we see really quite stark disparities of use. And so this I just grabbed one, screenshot as an example, which is showing the difference between rural and urban, and the difference is pretty noticeable. So to kind of summarize these findings, what we know is there are some common barriers to using telehealth that we've talked about already. And there are some important characteristics of specific users that we know about, but we still have a lot that's unknown. So some of the unknowns are specific barriers for use cases. So specifically, behavioral management of nursing home residents with dementia, and then staff training and support. We also don't know when these barriers impact the process. And that's a really important factor to consider when we're trying to improve implementation and when we're studying it. The strength of the barriers, so the impact. So not all of these barriers are equally weighted. Some are impacting adoption and use more than others. We also don't know the motivation for telehealth use or non-use. And in addition, we don't know family resident preferences and how we might use telehealth in a way that leverages workflow efficiencies. So this leads me into the study that I've just started recently. And the name of that study is Enhancing Dementia Care, Bridging the Rural Gap with Telehealth. And the overarching research question, put simply, is why is telehealth use in rural nursing homes so low? And how can it be implemented to improve access to behavioral health care in rural nursing homes and to improve nursing home staff ability to care for nursing home residents with dementia, whether that be through training, workflow efficiency, or burden reduction? And then ultimately, how might these improvements result in improved outcomes, including reduced avoidable nursing home to hospital transfers? The framework or the conceptual framework that I use to do this study is called the Consolidated Framework for Implementation Research, or the CFIR. The framework was originally published in 2009 and it was updated in 2022. It's a practical framework that's used to guide systematic assessment of potential barriers and facilitators, which in implementation science are referred to as determinants. This information about determinants can then be used to tailor strategies that explain outcomes. The CFIR model has a menu of constructs that are arranged across 5 domains. The domains are the outer setting, the inner setting, individuals, the implementation process, and the thing or the innovation. And so when I think about what we already know to be barriers of telehealth use in nursing home, um, it was quite easy to fit those into this framework. And that's, one of the reasons that I chose this framework for the study is because I did see a very clear connection to many of the barriers and to these constructs in the framework. So for example, technical difficulties that could fit into intervention and also the inner setting. When we think about reimbursement challenges, that's a component of the outer setting. Resident and family preferences relates to individuals. A lack of Wi-Fi or cellular broadband connectivity is related to the inner setting. And then we have workflow bottlenecks, which comes into play as part of the process of implementation. Sorry, I got a little ahead of myself. Um, so for this study, we proposed 3 aims. The first aim is to assess determinants that explain the wide variation of implementation of telehealth in rural nursing homes using the CFIR model. In aim 2, we'll identify potential implementation strategies by mapping strategies to identified determinants. And whereas for aim 1, we're going to use surveys and also semi-structured interviews, in aim 2, we'll integrate the results from aim 1 with literature review and then something called the ERIC strategies, which I'll talk more about in just a moment. And then finally, aim 3 is to rate potential implementation strategies in terms of importance, feasibility, and impact. We'll do this using a modified Delphi approach with experts who will be able to speak to these kind of factors when it comes to implementation. So I wanted to give you kind of a concrete example of how we went about the process of designing our nursing home telehealth survey. So this example relates to the CFIR domain of innovation, which is the thing being implemented, in this case, telehealth. And these resources that I'm about to share and talk about are available through this website, cfirguide.org. So I encourage you, if you're interested in implementation science or how the CFIR has been used, how you might use it, how it's been modified from its original form, I encourage you to go to this website because there are just a host of resources that I found incredibly helpful. So the construct, for example, that falls under this domain of innovation is called evidence-based. And the definition, which is from the website, is innovation that has robust evidence supporting its effectiveness. Again, in the resources, there are questions that have already been developed based off of the CFIR model. And so the question originally that was proposed is, stakeholders have a negative impact of the quality and validity of evidence supporting intervention. When it was time for us to tailor that or to customize it for our nursing home telehealth survey, I really was mindful of the burden of survey respondents. And anyone that's done a lot of survey research like I have knows that it's a problem. And we want to do anything that we can to ease that burden for the participants, which will in turn improve our response rate. So one of the first things I wanted to do was reframe that into a positive. So the initial question was, there is robust evidence supporting the use of telehealth in nursing homes. The next thing we did in our design process is something that's called a think aloud. And a think aloud is a component of human-centered design. It's a strategy, whereas we ask a participant to go ahead and take the survey. We did this on a live recorded Zoom call. And during that recorded call, they're taking the survey on RedCap as they would be doing, if we weren't recording it. But we have members of the research team that are asking questions, and we tell the participant, as you go through the survey, say everything out loud that comes to mind. If a question seems unnecessary, if it's redundant, if it's difficult to understand, if it's confusing, if something is unclear, we want to hear about that. And if the participant isn't saying enough of that, then the members of the research team can probe that and say, things like, oh, I see you paused there. What are you thinking about? And that process for us was incredibly helpful. So if you're considering any kind of a research project like this where you might be able to incorporate a think aloud, I would highly recommend it. And I'd be happy to share some of the resources that we used in doing that. And as an example of the modification that came as the result of the think aloud, we changed the question, simplified it even further to there is strong evidence for implementing telehealth in nursing home. And so when I look back on that, I think, oh yeah, that's way more clear, much easier for a respondent to be able to answer that compared to, the original question that was proposed in the model. So, just an example of how we've been able to tailor our survey using some human-centered design approaches. The final survey has 34 questions, not including demographics, and respondents are asked to rate items on a 7-point Likert scale. I chose a 7-point scale because that lends well for psychometric testing, and that's not the primary goal here. It is not to develop a valid and reliable instrument, but if you're going to go through all of this process of developing and customizing, tailoring a survey, why not go ahead and set it up so that if you decide down the road to do some psychometric testing, that's available. So next steps are to continue to collect our survey data. We launched our survey about a week and a half ago, and I think we have 10 back. So we're slow but sure, and our goal is 150. So we've got a ways to go, but we're optimistic about our 10 that we already have back. We're going to follow up with some surveys with semi-structured interviews to try and develop even a more contextual understanding of some of these determinants of implementation. We'll do mixed data integration with our survey results and our qualitative interviews and triangulate all of that to help inform AIM 2, which is to map potential implementation strategies to determinants. This mapping comes by way of the expert recommendations for implementation change, or ERIC strategies. These were developed in 2019 by a group of implementation researchers and practitioners that were asked to select the strategies that they thought would be most impactful. And so they were kind of grouped together in two sets of recommendations, what's called level 1 recommendations, where the majority of the panel recommended this strategy, and then level 2. This is also available on the CFIR website. This is just a screenshot of those results. And you can see the ones in green reflect the level 1 recommendations, and the level 2 are in yellow. And when I think about mapping the determinants as they relate to telehealth use, this is an example of what could be. So this is a hypothetical example, not based on our work, because we're not there yet. But I still wanted to be able to, for the sake of conversation, to include this. So for example, if the cost is one of the barriers that our participants identify as being a barrier to implementing telehealth, that aligns with the CFIR domain of innovation. And these are some of the potential strategies from the ERIC spreadsheet that could be used. However, if we go take this to a nursing home decision maker and we say, oh, all you need to do is come up with new funding or new incentive structures, I think they're going to laugh us out of the room. And so what we need to do next is understand which of these are actually feasible and which of them have the most potential for impact. And so that's what we'll do in AIM 3 using a modified Delphi. We'll convene a panel of expert stakeholders. These will include healthcare professionals, policy experts, administrators, research, and then some caregiver and resident advocates. And the panel members will be asked to rate these strategies in terms of importance, feasibility, and impact. We'll do this iteratively in 3 rounds until we achieve consensus. And so what I anticipate, or I hope that the final product is what I'm going to call an implementation blueprint. And it's a prioritized list of telehealth strategies. And I hope to be able to present this to decision makers as sort of a menu. Like, here are the menu of options. If this is what's important to you, these are the things that you could do to help guide your implementation of telehealth. And then they can kind of pick and choose based on what's realistic given their resources and their setting and their patient population. So in summary, I just want to I think we're about at time. I want to save some time for questions. Thanks everyone for attending. Please feel free to contact me if there's anything that I've said that you'd like to follow up on. There's my email address. If you'd like to learn more about our nursing home telehealth study, I have a link to a YouTube video where I talk a little bit more about this study. And then also, just a shameless plug, we are hiring a postdoc for this team. And so if you know someone who's going to be graduating soon or has recently graduated and might be a good fit here, we would welcome referrals for potential postdocs.
As always, that was amazing, Dr. Powell. I feel like I learned a lot from this talk. I know we've talked about your project just offline before, but I guess right now we'll turn to the audience for any questions. I have some questions, but I want to make sure that we hear from the audience. So I think
I'm not
you could
seeing
put it in the
questions quite
Q&A.
yet
I'm
coming in the
monitoring.
Q&A, Jen, but hopefully people will go ahead and put their questions in the Q&A. But it looks like Susan may be unmuting herself to
Yeah,
ask
I
a
have a question. This is about the CMS decision to not cover telehealth visits in the same way they covered them during the pandemic, which does include exceptions for rural areas, although I don't know if they've defined rural areas. So what do you know about that and how it might impact nursing homes, if at all?
Yeah, that's a great question. And I think your point about how rurality defined is maybe the most important question that is part of that. Um, and, it's so variable. And, many different researchers do it different ways. Some look at RUCA codes, others look at, other ways of defining rurality. In our study, we've decided to use self-report. We're going to let our respondents tell us if they think they live or their nursing home is in a rural area, because we've got rurality, but we've also got nursing homes that are quite isolated. They might not fit that, designation as a rural facility, but they may be quite isolated and not have access to providers. So I do think that the changes that are set to potentially expire could be devastating for nursing homes. And it honestly scares me quite a bit when I think about especially nursing homes that have grown to rely on this service to improve access to care for their residents. And that's how they're kind of getting around it and bringing in specialty providers who they haven't previously had access to. So, I think it's just one of those things where we have to advocate, we have to contact our legislators and tell them about this work that we do. And, hopefully they'll see the value and these changes will be made permanent. But I guess we're all waiting to see.
Thanks. And just, do you know if CMS has defined rural?
Uh, not that I know of.
Okay.
I'm sure we could find a definition somewhere. There has to be, but I just don't. I'm not aware off the top of my head. In our prior work, we use RUCA codes.
Yeah.
This is the first study where we've taken a different approach. Yeah.
Yeah, I tried to look at that decision and I couldn't find anything, so maybe it's still in process. Thanks.
Any other questions? I am monitoring the Q&A from the audience. So far, there hasn't been anything, and I will also, my center director always says, wait for 7 seconds. If nobody else has a question, I actually had a question. As I was listening to your talk, telehealth and telemedicine, all those things leverage technology. And as you highlight in your talk, there are different tools, like digital tools that we could use. I'm just curious, and maybe we're not quite there yet because we're still struggling to implement as simple, I mean, I shouldn't say simple, but what's already existing. But what do you see as like how the role of AI that's going to play in, I don't know if that is anything. I know that's not something that you cover in your talk, but it just really made me wonder about how maybe it's the combination of AI and telehealth, maybe another way to kind of think about this.
I think you're right. I think you're spot on, Jen, with with kind of an integration. I could see how AI could be integrated into a telehealth or a telemedicine encounter to help address some of these problems that we're having with like interoperability and burden, documentation burden specifically. There's opportunities to integrate clinical decision support that I think could be extremely valuable given a telehealth, telemedicine, situation. So yeah, I think maybe we're not quite there yet, but that should be the direction that we head into. I think it's a really good point.
Actually, I have a question for you, Kim. This was really a wonderful presentation. I have to say, I think you provide so much great landscape of the state of the world of telehealth in rural areas, plus how it treats, helps with people with dementia. I was really kind of struck by your comment in particular, how maybe some patients are not clear what this technology is and how it may, impact, like, why is it talking to them? I think that kind of concept is really kind of an interesting one. And I'm curious whether you think there's going to be a generational effect, or if that's just something specifically about people with Alzheimer's. And then second, I guess, I have in my head, so that's looking into a crystal ball. I realize, like, you
Mhm.
probably don't know that for sure, but I would love to just get your thoughts on it. But I think the other one is also wondering about, the conversation during COVID was how a lot of people use like FaceTime on iPads, right? And that's a fairly easy tool. I'm not an iPad user, but I certainly know that that's something that's a little bit more intuitive than, say, sometimes Zoom. I watch my own parents struggle with trying to get on a Zoom call, and it's just the switching of platforms. And I'm just curious where like the human factors kind of start versus where the technology pieces and like the poor integration and the creation of the technologies that we have, where that starts. So like how much is it that we're trying to fit the human to fit the technologies versus the technologies needing to fit the humans? And you touched on that a bit, but would love to hear more.
Yeah, I do think there is some work being done to develop, telemedicine, telehealth delivery systems that fit better, right? But we're still not quite all, to the human factors model of let's design it from scratch based on the end user. And I think you make such an excellent point about, the intuitiveness of the different kind of ways that you can use telehealth. And that came out in our previous studies where, some nursing homes had used money that they received during the pandemic to purchase iPads, and others already had like really sophisticated integrated telehealth equipment where you could place the stethoscope on a resident, and a provider in a different state could, hear the breath sounds or do that assessment. So there things like that exist. And it was, it really became important in our studies, whether, that was that kind of determined whether or not they perceived telehealth to be useful or not, what kind of equipment they were using, and how much time they spent training and orienting their staff to use that equipment. Because just like you said, it's one thing to take someone who is kind of technology naive, hand them an iPad and say, okay, go do this telemedicine visit versus giving them, some other piece of equipment that maybe they've never used, is not intuitive to them to use. In terms of your first question about, is it a kind of a generational thing? What we have found, it not only in this work, but also in work that I've done with patient portals and thinking about how people use patient portals and what are the factors that increases their use, especially when we think about how they using them for self-management tasks. And, you know, oftentimes people think, well, it's the age of the end user. That's what it is. So older adults, they don't want to use technology. They're not interested in this. It's just not, that's not it. But what we found in our patient portal work, but it's actually the age of the provider that matters more. Our patients would they would pull out their phone and say, "Oh, this is how I access my patient portal. I wish my doctor would tell me what I should do on here because right now it's just, all this data." But the providers, when we interview them, they're like, "Oh, our patients don't want to use that." And that wasn't the case at all. So that was, I feel like a lot of the findings from that study, although it was completely different, kind of translate to this. And then, as far as using technology for patients who are cognitively impaired, have a diagnosis like dementia, we just don't know. And I think we've only just scratched the surface for this. And I was not expecting that finding at all when they said, oh, well, it's really hard for some of our residents, but not all of them. And our ones that have dementia are really struggling. They just don't understand this at all. And actually, it's kind of scary for them because they're like, why is the computer talking to me? That's really weird. So that was one of the reasons I wanted to, in my new study, really kind of focus in on that population and say, how can we use this technology in a way that is, not scary, that improves outcomes and is sustainable? Because, like those slides I show you with that graph that goes straight up and down, I just feel like that is so problematic, right? To take the time and invest. And I'm rambling. I'll let you
No,
interject.
I have so many more questions. I mean,
Yeah.
you open up such an interesting kind of line of inquiry, and you've certainly made some great inroads in this space. So I hope people take inspiration too here from the talk today. But I know we're kind of coming up on time, so maybe I'll go ahead and close us out here. But I really do appreciate your time today, Kim. It was wonderful kind of hearing about your work. I think I'm definitely going to be using that framework you created in 2021, and I'm glad to see your work getting picked up by NAM. So thank you for taking the time today to present to our network, and we hope to continue engaging you in the future. And thank you to everybody who joined today. And again, this is recorded, so please share this out with folks. And Kim, I think that postdoc that you pointed out to there at the end will certainly make sure people are aware of that.
Great. Thank you
Thank you
so
for sharing.
much.
Have a wonderful day, everybody. Bye.